So good afternoon, everyone. I hope you've had a good day so far. So welcome to the fifth case study in our series on the monthly case studies. So today's case will be on endocrinology 3, that's what we've termed it, water and electrolyte disorders. So going by from our practice and from what we encounter on a day-to-day basis, we know that electrolytes, which of course involves water as well, are some of the most common ordered tests in any hospital setup. And it is not always, at times, easy to do the interpretation because at most times we don't have complete clinical information. So with us today to take us through that very important topic, that pertinent topic, is Ms. Isobel Hambleton. So by way of background, Isobel Hambleton is a senior clinical scientist at Berkshire at the Surrey Pathology Services. So she has an undergraduate degree in biochemistry. So she's done some research projects on therapeutic drugs, specifically covering tuberculosis. She's also had some stint at Emory University, focusing on global health and HIV research. She's also done a master's at the University of Cambridge, looking at the immune evasion strategies of Trypanosoma brucei. But she has then focused her interest in clinical biochemistry, obtaining a master's degree in clinical biochemistry from the University of Manchester, and completed her NHS scientist training program. So Isobel will have a case report that she will present, and then after that there'll be some discussion. So there'll be a Q&A session at the end of our presentation. So at that time, you can chat your questions in the Q&A box, or raise your hand, and Roxanne will unmute you, and then you can ask your question. So after this presentation, Roxanne will also share the survey link via the email. You are all encouraged to respond to the survey just to help us improve these sessions, and also get to find out how useful they are. So with us, Isobel, are residents in chemical pathology, in clinical pathology. We also have clinical scientists, and we also have qualified young pathologists. So without further ado, I now hand over the session to Isobel to present the case and lead us in the discussion. Over to you, Isobel.
Thank you very much for the introduction. So I have prepared some cases. I'm going to start with the two top cases there, case 1 and case 2, on hypernatraemia and hypercalcemia. And if there's time at the end, I've got 2 shorter cases that we can go through if there's any time left. So firstly, case 1 is a pediatric case of hypernatremia. So firstly, just a bit of a background about this patient. So it was a 9-year-old female. She presented to the family doctor with 3 to 4 month history of weight loss, excessive thirst. She was drinking more than 3 liters of fluid every day. Frequent urination, including during the night, which was upsetting her sleep. She complained of feeling tired and she had occasional headaches. So the initial tests that the family doctor did, I've got the results here. So as you can see, this confirmed that she had hypernatremia with inappropriately dilute urine. So the doctor ordered the blood test, but also this urine osmolality. So that urine osmolality at the end is just a random urine. It was taken, I think, in the evening. It wasn't a particularly timed urine, but we can see there that there's only 85 millimoles per kilogram, which is a very dilute urine. And that's inappropriate for that very high sodium that that patient has. So there's lots of possible causes of hypernatremia. And they can sort of be split into three different components. So one of them is free water losses. So we see that quite a lot in clinical practice. Firstly, gastrointestinal losses. So if the patient is vomiting, that's a really common cause. But in this case, the patient didn't report that she's been vomiting at all. Also osmotic diuresis. So if the patient has high glucose, the body is trying to get rid of that glucose in the urine, and then the osmotic effect of that is that it draws water out of the tissues. Renal concentrating defects also result in free water losses, so things like diabetes insipidus. And you can also get skin losses if the patient has been sweating a lot or has had severe burns. Other causes include water deficit. So if the patient hasn't been taking in enough water, and that can be common in an unconscious patient. Also in infants who are unable to breastfeed, they can become dehydrated very quickly. And also if the patient has an impaired thirst mechanism, and that can happen in elderly patients, where we see that quite commonly. The other cause, or the other classification of causes, is sodium overload. This is quite rare, but it can happen if the patient has ingested a high volume of sodium, for example, if there been a near drowning incident, if they've ingested a lot of seawater, if they've been poisoned, for example. It can also happen in a hospital setting if the patient's been given hypertonic saline, for example. Also mineral rallocorticoid excess, so in Conn syndrome, and also steroid use can cause that. But in this patient, what they thought first to do was to rule out that the patient had diabetes. So we're looking at that osmotic diuresis. And so the initial tests for this patient in the family doctors was that they did a urine dipstick, found no glucose, blood, or leukocytes in there. They used a portable glucose meter, and no glucose, just a normal random glucose within normal range was found. They also did an HbA1c, which came out normal. And I should note here that HbA1c isn't really recommended for patients who are quite young, and it's possible that they might have type 1 diabetes, because that can develop very rapidly, and that can give a normal HbA1c result. But they did that anyway, and it came back normal. They also checked the serum calcium, because hypercalcemia can also reduce in polyuria, but that came back normal. I did a celiac screen, and that was normal, and the full blood count also came back normal. So the patient was admitted to hospital, and she had to fast overnight and had no fluid for 10 hours. And again, they confirmed that urine osmolality was very low. That's a very low, very dilute urine, which is inappropriate with that high sodium. So this is pointing towards a problem with concentrating the urine. And it's pointing towards diabetes insipidus. So in a normal patient, the pituitary gland sends ADH hormone to the kidneys to control how much urine is made. So when the patient is dehydrated, you should get increased production of ADH hormone so that the kidneys reabsorb more water. However, in diabetes insipidus, the pituitary gland either isn't producing enough ADH, or the pituitary gland is producing enough ADH, but the kidneys are not responding to it. And the result is that you get very dilute urine, even if the patient has a high sodium. So they carried out a water deprivation test, which involves the patient being admitted into hospital. They have a line put in so they can take serum samples throughout the course of the day. They also collect all the urine that is produced. And it's really important in these patients that they are monitored really carefully, because these patients are incredibly thirsty. This is really, really unpleasant for them. So they have to do things like making sure there's no water in the room, that things like if there's a vase of flowers, for example, that there's no water in that, because these patients are really, really desperate to drink anything that they can. So the patient has to be monitored by a lot of staff throughout the course of the day. So for this patient, the test started at 8 o'clock in the morning. And they tested the serum osmolality throughout the day. And we get the samples in the lab and we have to process them as soon as possible. It should also be noted that it's really important to monitor the patient's weight throughout the day. So if the patient's weight falls below 5, if they lose more than 5% of their body weight that they started at in the morning, then that shows that there's really serious dehydration and they have to abort the test because it just becomes too dangerous. So they did that throughout the course of the day for this patient as well. So we can see at the beginning of the day at 8:30 in the morning, the patient's serum osmolality is 303. And by 12:30, that hasn't really increased. It's sort of stable, but the urine osmolality should be increasing, but it's not really. It's increased a little bit, but it's not, even though the patient is producing lots of urine. At just after the 12:30 sample, the patient was given 1 microgram of desmopressin intramuscularly, which is synthetic ADH hormone. And after that point, you can see from the urine osmolality results that the urine is starting to become less dilute. The osmolality is increasing, so that she is able to concentrate her urine if she's given the synthetic ADH. So this points to a diagnosis of central or cranial diabetes insipidus. So the kidneys are able to respond to the ADH, but it looks like it's not being produced properly in the pituitary gland. We also tested copeptin, which is a precursor peptide of ADH. That test takes a lot longer to come back. But a few weeks later, we had this result, and the copeptin concentration under hyperosmolar stimulation, as was in that test, confirms that this is central diabetes insipidus. So she was started on desmopressin, which is sort of like synthetic ADH, 50 milligrams twice daily, and this helped her a lot, and her water intake reduced to 1 to 2 liters per day. So from her point of view, she was still having the headaches, but she was feeling a lot better. And she was sleeping a lot better because of the reduced urine output. But what they wanted to go on and do was to find out why she had this diabetes insipidus. So they started doing MRI imaging. So 2 months after the initial presentation, she had an MRI, and it showed that there was a 10 millimeter lesion on the pituitary. There was no paracellular abnormality and no optic chiasm compression. So her vision wasn't being affected at this stage. There was normal myelination, and they decided there was no need for a biopsy at this time. But they were advised to check the AFP and HCG just to check that, to sort of confirm that there was no need to biopsy it and there was no signs that this tumor was malignant at this point. So they did that, and those came back normal. And then they tested the rest of the pituitary hormones. And we can see here that the TSH is low and the free T4 is also low. So this indicates secondary hypothyroidism. So this shows that the pituitary gland, the ADH production is affected by the tumor that's there, and also the thyroid hormones are also affected. The TSH is also affected. So she was started on levothyroxine at 50 milligrams per day. They also tested the other pituitary hormones. They had no concerns at this point about the FSH, LH, and estradiol. They were normal for this patient's age. Prolactin was normal. And also the patient's height was within the expected range compared to her parents, which suggests that growth hormone isn't affected at this point. They also did a short synacthin test to check the response of the adrenal glands. So at 8:45, the cortisol was 128. She was given the synacthin, and then at 9:15, 30 minutes later, her cortisol level had gone up to 609, which shows that there was an adequate response to synacthin. So at this point, they were happy with that. So later, after the initial presentation, they carried out more MRI imaging. And this was because she came in as an emergency case in eye casualty. She had double vision, she had pain around the eyes and swelling of the optic disc, headaches and dizziness. And the MRI lesion that she previously had grown to 17 millimeters, and it was causing displacement of the optic chiasm. So surgery was planned. And the surgery was successful. She had endoscopic transfernodal pituitary surgery for aspiration and biopsy of the tumor. There was no evidence of malignancy, which was good. And she became free of headaches and visual symptoms after the surgery. The damage to the surrounding pituitary tissue was evidenced by the failed short synacthin test that she had 2 weeks after surgery. So she had to be started on hydrocortisone. So that shows that the pituitary surgery has affected her ACTH production. But otherwise, this patient continues to be well. So just to summarize that case, this was a 9-year-old female patient who presented with headaches, polyuria, and hypernatraemia. After ruling out more common causes such as diabetes mellitus, a water deprivation test confirmed that she had central diabetes insipidus, which is quite a rare disorder. The MRI of the pituitary glands showed a pituitary lesion, and they went on to do pituitary function testing, revealing secondary hypothyroidism, which she started treatment for. Surgery was performed when she had worsening headaches and new visual symptoms, and the surgery resulted in damage to surrounding pituitary tissues, leading to ACTH deficiency. So she'll be continued to be monitored for all of her pituitary function, especially as she gets older and they're looking more at growth hormone in the future. So electrolyte imbalance, such as hypernatraemia, as shown in this case, can be a symptom of wider endocrine abnormalities. And as shown in this case, dynamic function testing can aid the diagnosis of a variety of endocrine abnormalities. As in this case, treatment often involves investigating and correcting the underlying hormone deficiency, or deficiencies in this case, because lots of different things were affected. The next case I've got is an adult case of hypercalcemia. So the background to this case, this is a 70-year-old male. He presented to the family doctor with generalized body pains, increased thirst and urination. So this patient has that increased thirst and urination that our first patient had. And initial testing showed that he had a very high calcium and low phosphate. And again, diabetes mellitus was ruled out as a cause of that polyuria, as shown here with his HbA1c of 31. But we can see he has a high adjusted calcium of 3.48 and a low phosphate. So what are the possible causes of hypercalcemia? So when a patient presents with hypercalcemia, firstly, it's important to look at the adjusted serum calcium, because the adjusted serum calcium is affected by the level of albumin that that patient has. A clinical assessment is needed to find out if there's any signs or history of malignancy, because malignancy is a common cause of high serum calcium. It's important to consider granulomatous disease such as tuberculosis and sarcoidosis. And also really important to get a full drug history, including drugs that a patient has bought over the counter, for example. So calcium supplementation is an example, vitamin D intoxication. Thiazide diuretics can cause high calcium. Vitamin A excess is quite rare, but that can cause high calcium. And lithium and antacids are also a cause. So the next thing to do is to measure the PTH. So the PTH is suppressed, then the possible causes are metastasis. So you might need a bone scan to have a look. Malignancy, other causes, other types of malignancy, possible lymphoma or multiple myeloma. Thyrotoxicosis can cause hypercalcemia, and Addison's disease can also cause hypercalcemia. If the PTH is normal or only slightly high, and that doesn't explain, especially if you've got a really high adjusted calcium, that you could look and see if the patient has familial hypocalciuric hypocalcemia by checking the calcium creatinine clearance ratio. This is a genetic disorder, and the patient is usually asymptomatic, and it can run in families as well. If the PTH is elevated, you're looking more towards conditions such as primary hyperparathyroidism and potentially tertiary hyperparathyroidism, in which the most common cause of that is long-standing chronic kidney disease. So for this patient, we have that high adjusted calcium. They have a low phosphate, and the PTH was found to be 40, which is much higher than the reference range. That's really, really high. And it shows that this hypercalcemia is being driven by that high PTH. There was no evidence of chronic kidney disease in this patient as a cause for the high PTH. So this is most likely to be primary hyperparathyroidism. An ultrasound of the parathyroid gland revealed a parathyroid adenoma. The next thing that they did was to check for end organ damage, because high calcium can cause lots of different problems in the body. So they did a renal ultrasound, and they found no renal calculi formed, so no stones have been forming in the renal tubules. They also did a DEXA bone scan, which is looking at the mineralization of the bones. And when the calcium is drawn out of the bones, you can get symptoms like osteoporosis-like symptoms. But for this patient, luckily, that was normal. They also checked an ECG several times throughout the course of this patient's admission, and they were monitoring that regularly, checking for cardiac arrhythmias, which can be caused by the high calcium. And the patient was started on cinacalcet 30 milligrams per day. That reduces the effectiveness of the PTH, and the patient was also scheduled for surgery. So the patient had a parathyroidectomy. So I've put here on what the patient's calcium and PTH were at on the day of the surgery. So on the day of the surgery, you can see that cinacalcet has reduced the calcium a little bit, but not that much. He still has a very high PTH level of 38.5 and a high calcium level of 3.02. Immediately after the surgery, where they taken out the adenoma on the parathyroid gland, the calcium has reduced. And 1 day post-surgery, the calcium has reduced even more, and the PTH has come back right down, which is really good news for that patient. 3 days post-surgery, the adjusted calcium and the PTH are normal. They continue to monitor. So as you can see, the calcium level at 6 days post-surgery actually drops, and it actually becomes on the low side. And you can see that the PTH level has now risen. And the likely cause of that is that this is now secondary hyperparathyroidism, probably because the vitamin D level is not really sufficient. So they started replacing the vitamin D, and the patient normalized. So in 2 months, the levels were now normalized. So it's important to note here that for this patient, they didn't have a total parathyroidectomy, so they still have their natural PTH production. That's still there. So the patient is probably not going to need to be on calcium supplements going forward. As you can see, everything is now normalized. If they had taken out all four parathyroid glands, they would no longer have any PTH production, and the PTH wouldn't respond to any changes in calcium, and the patient would have to be taking supplements of calcium to keep that normal. But luckily for this patient, he's now able to control his calcium levels himself. So, case 2, summary and learning points. So this was a 70-year-old male. He presented with body pains and increased thirst. The blood test showed that he had hypercalcemia. There's lots of different causes for hypercalcemia, and for this patient with a raised PTH, this confirmed that the cause of his hypercalcemia was primary hyperthyroidism. A parathyroidectomy was performed. It was a partial parathyroidectomy, and this resulted in temporary secondary hyperparathyroidism due to the vitamin D deficiency. So the measurement of PTH can be really useful in determining the cause of calcium abnormalities. It's a really important analyte that we measure in the lab. And the most common causes of secondary hyperparathyroidism is vitamin D deficiency and CKD. So I'll move on to case 3, which is an adult case of hypokalemia. So this is a 70-year-old female patient. She presented to hospital because she had a trauma injury to the abdomen caused by a road traffic accident, and this resulted in a perforated bowel. She was in hospital for a good few months after this, and the perforation was treated surgically. And she was started on total parenteral nutrition during her recovery. So these results are after she started on total parenteral nutrition, shortly after she started. And we can see here that she has a low potassium, she has a low phosphate and a low magnesium. And this is suggestive because of the history of her being on total parenteral nutrition and previously being in hospital for a long time, not being able to eat or drink properly because of her bowel complications due to the accident and because of the surgery. This is highly suggestive of refeeding syndrome. So what is refeeding syndrome? So when a patient has had malnutrition or starvation for a long period of time, the metabolism switches to catabolism. So the patient is breaking down proteins. There's glycogenolysis, there's gluconeogenesis. And this means that the protein, fat, mineral, and electrolyte and vitamins are depleted within the body. And the result of that is when you start feeding the patient again, giving them the total parenteral nutrition in this case, but it can also be oral, you have a sudden switch to anabolism, where you start building up those protein and fat reserves that you previously lost. And you start using fluids, salts, and nutrients and carbohydrates as a major energy source. Insulin is secreted from the pancreas, leading to protein and glycogen synthesis, and glucose, thiamine, potassium, magnesium, and phosphate are taken into the cells, and this leads to sometimes very rapid case of hyperkalemia, hypomagnesemia, hypophosphatemia, and thiamine deficiency. And you can also get salt and water retention. And this can be very, very dangerous for the patient. And you can also get a lot of swelling. So it's really, really important that we pick this up really early. It's really important when any patient who's been previously very malnourished comes into hospital and we give them any sort of treatment, it's really important that we are looking out for this. So what we do when a patient comes into hospital, especially if they're elderly, for example, is we're checking as soon as we start with that, giving them the nutrition, that their electrolytes are not suddenly dropping. So for this patient, we know that the likely cause of their hypokalemia is refeeding syndrome, which is a redistribution in vivo. So this top right box here, redistribution of the potassium into the cells. So is that not actually an overall loss in potassium? It's just a redistribution. Other causes of redistribution can be alkalosis. Also, if the patient is given a large dose of insulin, for example, some drugs such as salbutamol, which are beta adrenergic agonists, and then rarely hypokalemic periodic paralysis can also cause a redistribution of potassium in vivo. Another really important cause is redistribution in vitro. So when a blood sample is taken, and it's not stored correctly, if there's any heat, for example, then the potassium can move into the cells and cause a low potassium result in the lab. The other causes of low potassium are a true deficit. So if there's renal losses of potassium, so for example, different types of renal tubular acidosis, diuretics is a major cause. A lot of patients, especially elderly patients, are on diuretics. Other drugs like carbonic anhydrase inhibitors, DKA, so diabetes, ketoacidosis is a key cause of low potassium. Again, hypomagnesemia, antibiotics, so lots of other drug causes, mineralocorticoids, glucocorticoid excess, and then some much rarer issues with the kidney like Gitelman syndrome. The other causes of a low potassium are extrarenal losses, quite often poor intake, so alcoholism, patients often don't have a good diet, sweating, cisplatin, which is used for cancer treatment, cell synthesis, so in the correction of megaloblastic anemia, for example, and then losses such as diarrhea, fistula, laxatives, and vomiting. So very common if the patient has GI problem. The treatment of hypokalemia, oral potassium supplements such as Sandoz are used for mild hypokalemia and prophylaxis for patients with poor intake or known ongoing losses. Intravenous potassium therapy, usually potassium dissolved in sodium chloride, is required for very severe hypokalemia, usually when it gets to less than 2.5 millimoles per liter. But in this case, the hypokalemia was mild, and if we monitor it regularly and reduce the rate that the TPN is given, then the electrolytes return to normal, and that's what happened in this case. So she was monitored very closely over the next few days, next few weeks as she was being given her TPN. We monitored these electrolytes and they came back into the normal range. So summary of case 3. This was a 30-year-old female treated with total parenteral nutrition following surgery on a perforated bowel. The blood tests after total parenteral nutrition was started showed low potassium, phosphate, and magnesium, and this was indicative of refeeding syndrome. So, as shown in this case, slow introduction of nutrition in malnourished patients is critical, and the regular monitoring of electrolytes is absolutely essential for these patients. So I'll move on to our last case, which is an adult case of hyperkalemia. So the background to this case, it was a 40-year-old female. She had presented at an emergency department with severe swelling of lymph nodes and fever. And the initial blood test showed elevated potassium. She's got a normal sodium, but she's got this slightly elevated potassium, 5.6. Her urea, creatinine, EGFR were all normal. And there was no evidence of renal problems in this patient, which is a common cause of hyperkalemia. So looking at the causes of hyperkalemia at this time, firstly, it's really important to rule out pseudo-hyperkalemia. So EDTA contamination, for example, especially if the blood samples are taken in the wrong order, the full blood count, and the serum sample are taken in the wrong order. If there's IV contamination, if the patient's on a drip for some reason. Also in vitro distribution. hemolysis of the red blood cells or delayed separation, and then also release from the white blood cells and platelets. Fragile red syndrome is another uncommon cause. It's quite rare. Again, uncommonly, increased intake can occur. So iatrogenic, so possibly a drip, supplements, IV fluids, and herbal medicines. Again, this is rare, but it's something to look out for. Decreased output is probably the main cause of hyperpotassium. So decreased EGFR if the patient has renal problems and chronic renal failure, obstructive nephropathy, renal transplant, and drugs, which I've got more on in the next slide, and hypoaldosteronism, Addison's. Redistribution is another really important cause. So acidosis, insulin deficiency, so the opposite of what we saw in the other case, acute tissue damage, tumor lysis, so when the patient has been given a drug for cancer, for example, and suddenly those tissues are all broken down in the body as the drug takes effect, you can suddenly get release of potassium into the bloodstream. And hyperkalemic period paralysis. And then drugs, really important cause is drugs. So reduced aldosterone secretion can be caused by ACE inhibitors, angiotensin II receptor blockers, NSAIDs, heparin, antifungals, cyclosporin, tacrolimus, so many causes. Again, there's lots of drugs that can block aldosterone binding to the mineralocorticoid receptor, and I've listed those there. It can also inhibit activity of the epithelial sodium channels, so potassium-sparing diuretics, and you can also alter the transmembrane potassium movement. Beta blockers are a common cause. But for this patient, she was not taking any medications. She'd previously been well. She didn't have any other medical problems. And as we've seen, her kidney function was good. So then had a look at the full blood count, and you can see here that the platelets were very high at 832, and the neutrophils are also raised. So the significantly raised platelets poses a question: is this a spurious cause of high potassium? So the way we test that is to collect a paired sample. So 2 samples are taken at the same time from the patient, one into a serum separator or SST tube and one into a lithium heparin tube. The potassium in the serum separator tube was 5.6, which is high, as we've seen. And in the lithium heparin tube, the potassium was measured at 3.8. So this confirms that this is spuriously raised potassium, and it's likely due to elevated platelets. So what do lithium heparin tubes do? So potassium measurement was higher in the SST tube due to potassium being released from the platelets during clotting. But lithium heparin tubes are recommended in our lab when patients have platelets of greater than 750. So our electronic lab system will put an auto comment on the results every time we see a patient with platelets greater than 750, and they haven't sent us a lithium heparin tube, they've only sent us a serum sample. And that's one of the things we check when we phone out results for high potassium, because it's can often be very an emergency situation, for example. We'll also always check that the platelets are not elevated or extremely elevated more than 750, because that could be a cause of the problem. For summary and learning points, this is a 40-year-old female presenting with symptoms suggesting a possible infection. Potassium level was found to be elevated. Further investigation revealed that this was a spuriously raised potassium due to elevated platelets, and due to that potassium being released from the platelets as the blood clotted. So this case highlights that it's always important to consider spurious cases of abnormal analytes, such as contamination, when looking at the results. It's also important to think about how long it took between the sample being taken and for it to arrive at the lab, for example, because that can cause spurious results. Also, how the sample was stored. So if it was properly stored, or was it warmed or cooled, for example, before it was separated. And again, this case exemplifies that a full medication history, including over-the-counter supplements, should be obtained so that you can rule out or rule in causes of those abnormal electrolytes. So overall, conclusions to these 4 cases. Electrolyte disturbances can be caused by a huge range of different endocrine abnormalities. We've seen several different types here. Sample handling and possible contamination is really important. Always consider things like drip arm or EDTA contamination, especially when those results do not fit with the clinical picture, and especially when you've got a whole string of results and one of those results looks very different to the others. Treatment really depends on the cause of abnormality, and as you've seen here, it's quite rare for sodium, potassium and calcium abnormalities to be treated by actually giving any of those electrolytes. Normally, we're looking at the causes of the abnormality and treating the cause rather than the end picture. And dynamic function tests, as we saw in that first case, are often useful for contributing to the investigations. So thank you. Do we want to move on to the questions?
Thank you very much, Isobel, for those very engaging and very interesting cases, and which I consider to be very practical and what normally we would encounter at the clinics or in the lab, and explained discrepancies in the electrolyte where you may not always have a clear pattern. So I think you brought out very clearly some of the approaches and some of the possible reasons, and I mean, for those discrepancies. And of course, I think the pre-analytics and of course the physiology, or what could be, or the pathology that could be happening in the body. It's good then to basically have all that information with, I mean, in mind. And of course, as we put it, to also consider all the other causes or all the other possible reasons that might also affect the water, especially for sodium metabolism. You cannot look at sodium and forget to look at what else might affect the water. So at this juncture, I would want to welcome Professor Akande to lead us in the Q&A session. So Professor Akande, please, you can lead us in the Q&A session.
Thank you very much, Daniel. And I want to thank Isobel too for the brilliant presentation, particularly for the diverse cases that you have gone through. The participants are ready, I'm sure, for the question. But I have one in the Q&A. I don't know if I can read it out. This is from Douglas Manga. It said, in case 1, why was the short synaptin test done? I think, Isobel, you can go on to answer now while we expect some other questions. Please, participants, you can put your question in the Q&A, or you can raise up your hand and we'll let you have your comments or your questions. Thank you.
The short synaptin test was done because they wanted to check the adrenal function, but they wanted specifically to check whether ACTH production in the pituitary was intact. So that's why they did the short synaptin test. And you could see later on the patient failed the short synaptin test after the surgery, and that's possibly because the pituitary gland was damaged during the surgery, and that's affected the ACTH production.
you very much. While we send in their questions or raise up your hand, I just wanted to say a comment. Most of our hyperkalemia that have documented are actually due to the mode of sample transportation. Some of these patients or patient relatives are very anxious, and when samples are taken from the wards and are given to them to take to the laboratory, because of their anxiousness, they're usually a form of shaking vigorously the bottle volume, the sample volume within the bottle, and it leads to a lot of analysis. And one analysis that are done usually finds, but I think it's very, very interesting that you brought out the angle of the platelets. And I think a lot of the participants will benefit from this case report that you did. Participants, please, can you raise up your hand and ask your questions or comments? We're waiting.
Proper Kande, we actually have one from Ade, so I'm just going to allow them to talk and ask their question. And we also have a few in the Q&A box, so I'm going to allow Ade to talk now. Please go ahead, Ade. Thank you. Okay, Prof, I think whilst we're waiting for Ade to talk, there is a question in the Q&A if you want to go ahead with that one and we can come back to Ade.
I have just one question in the Q&A, and I think we have responded to it.
Oh, no, there's another question here, Prof. I'm happy to read it if you would like me to.
Okay, I've seen it.
Great.
This is from why was albumin tag has been high in case 2? The value was 43.
Sorry, I just have to go back to the original case. Human.
Yeah, in case 2.
Oh, in case 2, sorry. Just finding it. Albumin. I see. Sorry. That's a mistake. It shouldn't say high. Yeah, I can see the albumin's 43 and that's within the reference range. Sorry about that. Good spot.
Okay, we have sent a chat message to Dr. Ade Ajala for his comments. I'm awaiting more participants' comments and questions.
We have another question, Prof, and comment in the QA box ready for you.
Okay, thank you very much. This is from Dr. Zainab Ibrahim, Gosdas. Thank you very much for sharing your experiences. From my side, during the course of evaluating patients with polyuria, we have had a few cases of psychogenic polydipsia. Can you please share your experience on that if you have any?
I have certainly seen when looking at water deprivation test results that there's actually a lot of patients who have a water deprivation test performed and they find everything is normal and they think it's probably psychogenic polydipsia. I think it's quite common. I don't really know what we can say the causes are. But yeah, certainly that's something that we all often see as well. So it's interesting that you're seeing that too.
Okay, we also have another question, Prof or Daniel, if you'd like to read it in the chat box, please.
Can you share more light on diagnostic cutoff for partial central diabetes insipidus and partial nephrogenic diabetic insipidus?
I think the reason that we don't see that many of these is because when there is a when we have a patient that is between those thresholds, so when we don't see in the patient that I presented, there was an obvious increase in the urine osmolality after they were given the desmopressin. But I think the reason that I don't personally see that many patients followed up in our hospital is because when it falls into a more middle ground, then those patients are referred to more specialist centres. So they're referred away from our hospital and referred to places in London for further testing. So I'm sorry, I don't have more information on what they then go ahead and do. I don't know if it's possible that they try the treatment that they would normally give for the nephrogenic diabetes insipidus and see if that helps, and also do the imaging of the pituitary. I would imagine they would go down those routes, but I don't know what cutoffs they use, sorry, in those specialist centres.
Much. There's another question which says, do you calculate
do we calculate, I think
calculate albumin adjusted calcium when albumin serum levels are within reference ranges?
Yes, the computer system automatically calculates adjusted albumin regardless of the albumin level. Every calcium result also has an adjusted calcium result. It's just an automatic computer generated.
Okay. And have you tried to compare the calculated values with when it is normal and when it is abnormal? I mean, when the albumin is normal or abnormal, so that is it a matter of what, automation or because of the fact that you're trying to get at something?
Sorry, I didn't catch the last bit of the question.
I said that is it a matter of being an automated system, or you're trying to get at something else? That's why you have to do all calculation.
I think it's just because it is easier to calculate it for all rather than getting the computer system to only perform the calculation for specific patients. I think that's the reason.
Okay. Okay. I want to ask a question. From my own practice, I found out that the sodium-based disorders are common in the pediatric age group. Why the potassium the age group? Do you have any experience along the same pattern, and what could be responsible for this?
Sorry, did you say, so you find that the potassium, sorry, I didn't, it cut out a bit.
Okay. Okay, what I said is that the sodium-based disorders, electrolyte disorders, are very common in the pediatric age group. Why the potassium-based disorders are common in the adult patients group?
Oh, so you're noticing that the sodium-based complications are more in pediatrics, and you see potassium more in adult patients.
Yes. So I'm saying, is that the same pattern you experience? And
I'm not sure. No, that's not something we've particularly picked up. I haven't particularly seen that. We see sodium, lots of low sodiums in particularly elderly patients. We see that quite a lot. But I wouldn't say I see an obvious distinction between pediatric and adult patients as you're seeing. But I haven't audited and I haven't haven't statistically confirmed that.
It's okay, thank you.
Do you have any ideas why you might be seeing that?
Basically, I think it's more or less the hypernatraemia, particularly in the pediatric age group. I think has to do with dilutional hypernatraemia in most cases, because the fluid, this pediatric age group is very, very difficult to maintain their fluid volume when they require any fluid therapy. So I think that is what is causing that. And like I did said earlier on, I think the hyperkalemia things are more or less, most times they are pseudo hyperkalemia. From, like I said before, sample transportation issues.
Yeah, we certainly
Okay, I
see
think
a
there's
lot
another question.
we certainly see a lot of the spurious high potassiums due to the delayed separation. We are trying to, at the moment, look at, because a lot of our samples are transported fairly long distances. We are currently trying to look at whether any centrifugation can happen earlier after the sample is taken. So if the centrifugation can happen where the sample is taken and then it can be transported to the lab, for example. But I think this is a problem for labs everywhere. I know particularly I have colleagues who work in Scotland on the Scottish Islands where they have to transport those samples by air, and they now are able to centrifuge them on site next to the patient, which has made a big difference to those potassiums. But I think the delayed separation and the transport of the samples is just, it's very difficult to really make sure that we don't get all of these spuriously high potassiums. And it takes up a lot of time for a lot of people as well, including the lab staff and the doctors that are investigating an over investigation of patients. So yeah, it's definitely a problem for us as well.
That's good. So, Prof,
Thank you very much.
yeah, Prof. I mean, if I may just probably just add on to your experience. So, I mean, for us here, as Isobel has said, most of our admitted patients, especially the adult population, I think our biggest disorder normally would be hypernatraemia. We do get lots of, or we do get some disturbances with potassium in pediatrics, but most of them would actually be pre-analytics, either sample or sample collection, either difficult sample collection and hemolysis. But I think it's also important probably that I also mentioned something that Isobel highlighted, which we often don't think, the influence of medications, drugs on the electrolytes, especially on potassium in diabetics. I remember there was one case where, as I said, sometimes you don't get all this history when you're doing the analysis. So a patient who had a persistent hyperkalemia, and there was nothing that could actually explain what the reason was. Only later to find out that this patient was actually a diabetic patient who had actually been put on captopril. So one of those ACE inhibitors. So there could be some of those hidden reasons that may not be obvious as to why you're getting some electrolyte disorder. So the medication history, drug history is also important. And then, of course, there are a lot of other, especially I think in pediatrics, some of these inherited conditions that affect the handling of electrolytes at the kidney. Rare though, but they can actually also be a challenge to diagnose. So there will also be some very rare causes, especially inherited conditions that one might come across in pediatrics that might give you quite some abnormal electrolyte disturbances. So it's also important just to keep that in mind about some inherited or some inherited conditions affecting the renal handling of the electrolytes. So important to keep that in mind as well. Rare, but it does happen. A number of syndromes come to mind. Over. Back to you, Prof.
Thank you very much, Daniel. I have some questions more. Isobel, if you don't mind, can I go ahead?
Yes, of course.
Okay. Well, this is the one. I think you have mentioned something about it. Thank you. When albumin level is greater than 40 grams per liter, will you still go ahead to calculate the corrected calcium value? I think you have answered this by saying that it is automated. So whatever value, you still go ahead to calculate. So let's go on to the next one. Very interesting one. It says, this is from Dr. Oladosu. Hypercalcemia linked malignancies is common here. Why, according to literatures, it is due to hyperparathyroidism in some other gland. What is your experience about this?
I don't think I quite understand. So you're saying hypercalcemia linked malignancies
It's
is common.
in his own area of practice. And it's saying compared to what is in the literature, it's usually due to hyperparathyroidism.
I see.
So what is your experience there in your own practice?
So I work at two different hospitals, and one of the hospitals is linked to a cancer center. So I certainly see a lot of hypercalcemia cases linked to malignancy when I'm there, and fewer of the PTH, the primary hyperparathyroidism cases when I'm there. But when I'm at the hospital, which is more dealing, where the lab is more dealing with the family doctor samples, yeah, by far the most common cause that I see is the primary hyperparathyroidism, and mainly in elderly patients. So certainly from the cancer center, I see a lot of those malignant samples, but that tends to be fairly rare, that they're not already being treated for cancer, and they're not. It's sort of a long time down the line, I think, that you'll see those hypercalcemia that's linked to malignancy. So it's very, very rare for us to pick up a high calcium outside of the context that is caused by a malignancy, outside of the context of that patient already receiving treatment and already sometimes on palliative care. I don't know if that answers the question. Is that okay?
Yeah, I think it's okay. I think it's okay. I think it addresses the question to a very large extent. The other one, document your comments about the will still be on the project website hosted by the Royal College of Pathology. And if they have missed any part or if the presentation is not very, very clear in some parts, I haven't seen anyone. Roxanne, have you seen any other questions?
No other questions at the moment, Professor Akande. Please ask your questions. We do have about 10 minutes remaining. So if there are any extra questions, just pop them in the box or raise your hand, please. I know Ade did have a question as well. So Ade, if you would like to say your question, I will allow you to talk.
Okay, thank you, Roxanne. Is Dr. Ade Ajala still with us?
Or also, if anyone would like me to go through a little bit of the presentation a bit slower, I can see that someone said. If there's a part that didn't make sense or you want me to repeat it a bit more slowly, I can.
Okay, that will be kind of you, Isobel. Dr. Akim, is there any area that you thought she was too fast for you to grab something? I think that was your comment. Otherwise, you still have the opportunity to have a second and many looks on the website of the presentation. Okay, what is your experience? I know this might not be common in your own area, but something again that I've noticed over the years is the misuse of fluid therapy, leading to a lot of electrolyte disturbances.
Um,
Do
I
you have any
certainly,
experience?
we certainly see a lot of, I don't know if we see many cases. Do you mean when, say, the fluid has been replaced too quickly, and you see the disturbances as a result of that?
Yeah, sometimes we see academic cases of electrolyte disturbance. For example, when samples are taken where the fluid is given, the kind of
Yeah.
dilution also that would be hyper. That's number one. Number two, because some of the arts officers or juniors are taking them, you know. So
Yeah.
when we have referrals and we go to see the patients, these are some of the things that we discover. Another one is the way the sample is taken. Sometimes there's a kind of microhemolysis when samples are taken too rapidly from the veins. Okay, so this sometimes leads to hyperkalemia. We have investigated so many cases. After we take some of these samples, and this has actually helped us to reduce some of these cases. That's just by way of context. Okay, there's somebody who sent in another question. Can you please throw more light on refeeding syndrome as relates to electrolytes and water disturbances?
I can go back 1 minute. Let me just share the slides again. So for refeeding syndrome, we see the bulk of our cases that we see for refeeding syndrome are elderly patients who at home, for example, before their admission into hospital, we call it the tea and toast diet. So they are basically not receiving all the nutrients they need in their diet. They might be living alone and not feeding themselves very well, and eating very little, especially very little protein. And when they come into hospital and they're treated for something else, so they have a surgery or they have a fall or something, when we are then giving them proper nutrition and proper cooked meals and that sort of thing, we can sometimes see this refeeding syndrome where suddenly their bodies have got quite used to that state of not having very high dietary intake, and often they're very thin and very frail. And then suddenly, if they suddenly have a better diet while in hospital, they're at risk of this refeeding syndrome, where the body changes its metabolism. Instead of it being catabolism, where it's breaking down proteins in the body, breaking down muscle, for example, suddenly the body has access to all these nutrients. You start producing insulin at greater levels, and that leads to this shift of the electrolytes into the cells. So it's not a loss of the electrolytes, it's just a shift into the cells, which then results in a lower levels of those electrolytes in the bloodstream. So it's when a patient comes into hospital, a lot of their weight and their nutrition status is documented and recorded, and any patients who are at risk of refeeding syndrome will be monitored much more closely. And the other patients that we see refeeding syndrome in when I'm looking at the biochemistry results are often patients with anorexia nervosa, for example. So they've got extreme states of starvation, and then they're treated in hospital where they're often put on enteral feeding, for example. And again, they're really checking the electrolytes really carefully. One thing we do have in some of the wards, not all of the wards in the hospital, is point of care analyzers. I don't know if we only have them on some of the wards, so they're not everywhere, but sometimes they'll be looking at the electrolytes at the point of care, so they can get those results, that the staff on the wards can get those results of those instruments much quicker than we can in the lab. And that means that they can adjust their nutrition much more quickly to avoid anything like refeeding syndrome from occurring. But though we can't measure everything on those analyzers, but at least we can measure the potassium and check that the potassium isn't dropping rapidly. So those are the general patients that we see. It's rare for refeeding syndrome to be very, very severe in a patient that has been admitted to hospital, because we're checking for it all the time. But it is very common in patients who have things like anorexia, where especially if they're being treated or they're not being treated or they're in their own home and they're not being monitored, then it's really quite common that we see that.
Well, thank you very much, Isobel. It's been a very wonderful time with you, and we appreciate your sharing this with us. I'm sure the
Thank you.
participants will have gained a lot from your case presentations, and we try as much as possible to be on the lookout for some of the highlights is very tricky. This will come in handy in the care practice of our participants along this. On behalf of participants, I want to say a very big thank you to you once again for your time. And I want to say thank you to Daniel for standing in for me at the beginning of the presentation. Can I kindly call on Roxanne for any in-house announcement before the session?
Thank you, Prof. So the next announcement is just I will be sending across a feedback survey. If people could please kindly fill that in, that would be really helpful. And we look forward to seeing you in the next case study session in October. Thank you very much.
Thank you very much, Roxanne. I think this ends the case review for this September, and I want to thank everybody for coming. Thank you very much.
Thank you. Goodbye.
Thanks all. Take care. Goodbye.